All right, but I think we can start now. So my name is Rose Griffin. I use she, her pronouns. I'm a study abroad ambassador. I'm a senior MB&B major here at Wesleyan, and I'm from Portland, Maine.
I'm Langston Morrison. I use he, him, his pronouns. I'm a senior at Wesleyan. I'm a double major in College of Letters and Economics with an International Relations certificate. I'm originally from Jamaica, West Indies, but I live in Stamford, Connecticut.
So we work with the Office of Study Abroad, planning events to share information about study abroad, but also working to increase engagement with the international community and expanding international education here at Wesleyan through events like this. And we're going to be moderating this event today. So over the next hour, we're planning to discuss what public health looks like on a global scale. So we have several questions prepared for our panelists, but also we have some time saved at the end for any questions anyone else may have. So throughout the meeting, feel free to send your questions into the chat at any point, and we'll save those for the end. But first, I would like to just ask each of our panelists to introduce themselves, your name, what your position is, and your pronouns, if you'd like, starting with Professor Shibley.
Hi, everybody. I'm Natalie Shibley. I'm a visiting assistant professor here at Wesleyan. I teach in the Science and Society program. And I use she, her pronouns. Generally, I would say my research is really in history of medicine, African-American history, and military history. So broadly, I'm interested in the US military as an institution that has created a large number of public health problems and has also done some research to try to resolve medical and public health problems around the world, and specifically also for its personnel. My research specifically involves a study of how the military treated sexually transmitted diseases as a public health problem, and how it also used the language of public health to discuss other sorts of issues, particularly homosexuality. So I look at both the actual policies, procedures, rhetoric around sexually transmitted diseases, but also the idea of sexually transmitted diseases as more of a metaphor for other sorts of so-called sexual deviance in the mid to late 20th century in the US military.
Great. And Professor Rhee?
Hi, everyone. Can you hear me okay? Okay, so my name is Greg Rhee, and I'm an assistant professor in the Department of Public Health Sciences at the University of Connecticut School of Medicine. And I also hold adjunct faculty at the Department of Psychiatry in Yale School of Medicine. So, so a little bit about my background is that I'm originally from South Korea, and I immigrated to the United States in 2004. So I have been in the US for about 15 or 16 years. And before pursuing my academic career, I also work as a social worker. So I actually have some experiences as a community social worker in Chicago area, where I engage a lot with the immigrant health and other immigrant public health issue. So for now, my current research, I mostly focus on the epidemiology of aging and mental health. So my primary research focus on depression, bipolar disorders, and opioid use disorders. So I use a lot of big data analytics to inform public health policy making, as well as clinical practice to shape medical practice. Yeah. Thank you.
And Professor Cohan?
Yes, nice to be here. Thank you. Yes, I am Fred Cohan. I'm a professor of biology and professor of environmental studies. I've been on the faculty here for 35 years. and I'm a microbial ecologist. Most of my research involves looking at diversification of bacteria and viruses. And recently, we've been looking at diversification within West Nile virus and within influenza to find ecologically distinct groups. And for the last decade or so, I've been getting particularly interested in global health, and I've been teaching the course Global Change in Infectious Disease.
Thank you. Excuse me. To start, I thought it would be good to discuss just more broadly the inequality that we see in the United States health system. So if just based on your research, what discrepancies do you see that exist in the healthcare system in the United States from access to treatments from access to healthcare to treatments themselves in the United States, but also globally if you have that experience? Just if anyone wants to jump on that.
So, well, I can start with the primary idea of what public health approach currently is. So we are primarily looking at the triple aim. I don't know if, are you familiar with the triple aim in the public health domain? So we are trying to address the access to care and quality of care and outcomes of treatment. So these are really the health outcome, treatment, the quality of care, and access to care. So, and there are a lot of issues across the different disease so it's really broad concept to address the public health issue. So, but when it comes to my research areas, I primarily look into racial disparities as well as minority health and minority aging for mental health and access to care in general. So I am trying to, I basically look into how access to care or barrier to care really affect the patient outcomes and also quality of life and quality of care of the healthcare system overall, affecting minority population in the United States. Some of my research also focused on how the language barriers and also the minority, the racism, like institutional racism would have an impact on access to care and the quality of care that they receive. It's really an interesting topic area, and I mean, I can talk for hours about different topics, but if you have more specific ideas to talk about, then I am also happy to talk about those.
Yeah, I would add, you asked about inequalities in healthcare. I mean, the fundamental inequality in healthcare, I would say, is that many people have no health insurance, so have minimal access to healthcare at all. So that's a pretty fundamental inequality. Also, we obviously have a lot of other healthcare inequalities, including ones that are perhaps not necessarily part of the formal medical establishment. So things that folks might call social determinants of health, or broader social conditions, economic conditions, and so forth, that are shaped by our various other social and political values that affect people's health, right? So that some people, even before they even get to a hospital or a clinic, are, if they have access to those things at all, are arriving with a variety of health conditions that are caused by or exacerbated by different sorts of social and living environments. So things like racial segregation, pollutants, and other sorts of toxic environmental conditions, which disproportionately affect African-American communities, but not exclusively. Also affect the sort of conditions that people might have, or how they experience those sorts of medical conditions, outside of the question of access to care. So the sorts of ways that people experience their own health is obviously affected by a variety of inequalities in the US. And then once people actually are, if, assuming people are able to get to a hospital or a clinic that isn't going to bankrupt them by seeking care, often the sort of experiences that people have with different sorts of medical professionals vary according to our other political and social inequalities, right? So especially like particularly salient identities like race, gender, sexual orientation, so forth, whether someone is on Medicaid and other things like that, affect how they interact with medical professionals, how medical professionals treat them, the sorts of care that folks are willing to provide, the amount of choice that they have between medical professionals, and things like geography, even like whether they have multiple doctors to even choose from. So the experience of actually being in a medical practice or hospital is also affected by broader inequalities that shape health inequalities and outcomes.
Yeah, I guess I can just talk. Yeah, so what I've come to see in my scholarship of this is that the American individualism that we're so proud of has gone off the rails to a kind of a toxic selfishness. And the thing that I see might be a solution to that with regard to disparities in healthcare and curing us of many diseases is to set up a virtuous selfishness where we help others because it'll help us. And this goes back to an idea from the turn of the 20th century called socialism of the microbe. And the idea is that it is good for us to prevent and cure infections in other people, lest their infections become our infections. And so this is actually very important in the sense that when we address poverty and infections of poverty, or infections of not having healthcare and so on, we're actually getting infections out of the circulation of the country so that we are less likely to get infected. And I'll just give one example of this, is with the case of HIVs. Now, HIV, we have the capacity to globally eradicate HIV through antiretroviral therapy. It's the technology is there. All we have to do is to give people the resources to get the healthcare to get their antiretroviral therapy. And you can see this in television commercials. You take this stuff and you're not cured of the virus, but it gets to be at a low enough level that you can't even transmit it. So surely, as just one example among many, it is advantageous for us, for anybody with lots of means, to give money so that poor people can get, and people, drug users and so on, can cure themselves to this extent of the disease. So I just want to, just very briefly, say that this idea of the socialism of the microbe deals with health disparities within our country, deals with investing in water supplies, public secure water supplies of developing countries, and even goes to the extent of investing in preserving the environment in the sense that there's a nexus between human health, animal health, and environmental health. Thank you.
Thank you all. Langston, you had the next question?
Yes. So thinking about, this is International Education Week, I think it's also important, that we think about, the different factors, maybe that influence the greater world we live in. So one thing to think about possibly is, would you say that there are, policies, actions, or interventions enacted by the United States which have affected public health on the global scale? And if so, could you describe those? Describe them.
So I guess that's a very interesting and really important question. So I think when it comes to the healthcare system, the US is really unique compared to other countries because, I mean, if you look at the statistic, basically the US, the whole GDP, about 20% of the GDP in the US are healthcare related. And so in the US in general, they spend a lot of money and they spend a lot of resources on healthcare system. And they also have a really good outstanding sources in terms of developing new biotechnology and other healthcare interventions. But when we also look at the health outcome at the same time, the US doesn't seem to be doing really well in terms of the mortality rate or in terms of the chronic condition like comorbidity rate, for example, like HIV and the obesity rate or some other chronic condition, including cancer, dementia, and like if you look at all chronic condition, like the US, the people in the US do not really do well in terms of these healthcare indicators. So what I can think of, there are two possible implications for those regions. So the first one is apparently the politics, because again, the healthcare system in the US is really fragmented. So if you go to the hospital, for example, it should be really coordinated. Otherwise, you will get really disappointed healthcare system, health services in general. So everything is fragmented and specialized into multiple specialties. And so that's one region. And also in terms of the access to care, the US healthcare system, they do not provide universal health insurance compared to any other developed country like European countries, Japanese, Korean, Taiwanese, or basically any other compared to those countries. The US health insurance is really employment-based health insurance. So a lot of people are struggling with not getting insured, especially in the COVID-19 pandemic era, that many people lose job, and that means they also lose healthcare access in terms of the insurance. So that's number one reason that the healthcare system had a lot to do with the politics, that it's really compared to other countries, it's really different and also difficult. And then the second reason is that I think it has to do with the health behavior of the individual. So not everybody are pursuing healthy lifestyle apparently in the US. So people are not exercising enough compared to any other people in the other countries, or they are more likely to engage in risky health behavior. So I mean, so those are the two regions that may be really unique in terms of the US healthcare system compared to other global competing countries. Yeah, that's my take. Mm-hmm.
I can add, I think you were asking about influence of US policy on global public health. And I'll say the things I'm thinking of perhaps aren't necessarily conceived of as health policy per se, but I mean, I studied the American military. So obviously a policy of having a war or an undeclared war or whatever, some kind of military engagement in another country, typically has extremely negative public health effects, and the U.S. military is all over the globe in all kinds of different ways. And we've some are highly publicized or highly debated, I guess, public health issues. I'm thinking of things like Agent Orange, for example, that have created like all kinds of health issues in civilian communities, but also conflicts on outside of like a war environment, like between people on a military installation and civilians. Right, often questions of sexually transmitted diseases can be a major issue of public health concern around all these installations that have been in the same place for decades. Other sorts of conflicts over environmental pollution from military installations, and including domestic ones like Camp Lejeune or something like that, where there's major environmental contamination issues from the installation itself. And then we have other sorts of sort of corporate effects on public health across the globe that perhaps aren't necessarily, I mean, they're sort of related to US trade policy, but they aren't like necessarily the US government doing them exactly, that affect some of the things that Professor Rhee was talking about in terms of like how people treat their own health, things like increased promotion of like fast food restaurants in other countries and stuff like that that aren't necessarily good for Americans' health either, and now have been exported to these other countries to create a market for those sorts of industries. And things like the automobile, right? A lot of, one of the major causes of death is automobile accidents. And of course, that also creates all kinds of environmental pollution and environmental issues wherever automobiles are used. And a lot of other countries have, and especially like in Europe and some Asian cities, have done a lot better than the US at having robust public transportation systems so that folks don't have to use automobiles like we do in the US. But I think the more, you know, the automobile is sort of like an international thing now. It's not just like an American product, but initially it was, you know, primarily an American industry. And so that's actually had a very negative public health effect as well globally.
I wanted to add one of my unfavorite military intervention examples to what you just said, which is the case of the Saudis bombing the Yemenis as part of the civil war. And we are supporting that, and we have been for some time. I suspect we probably won't into the next administration. But the problem is, beyond creating war in a case that's not necessary, is that there is a cholera epidemic going on in Yemen. It's one of the poorest countries, and partly as a result of just being exacerbated by the war, this cholera is totally out of control. So what should we be doing? What could we be doing? Well, one thing would be, cholera is a totally preventable disease, both by secure water supply infrastructure and also by simple vaccination. And that's what we should be doing in that case. And I just wanted to, in terms of the international arena of what we could be doing if we chose to, instead of this America First stuff that we're talking about now in our, you know, the government, is that if we could support secure water development projects in sub-Saharan Africa and other developing areas, that would mean that people in those countries would not be constantly getting bacterial diarrhea and so on. They would not be constantly taking antibiotics. And this is where it comes back to us, the virtuous selfishness, because when people around the world are unnecessarily taking antibiotics because their diseases could have been prevented, then what that happens is resistance in the world, antibiotic resistance in bacteria, gets ramped up around the world and contributes to almost 200,000 people in America dying every year of antibiotic resistant bacteria. It's just something that's real. And we could help prevent that by doing that virtuous selfishness stuff in investing in other countries.
Thank you.
Thank you for that.
For your, yeah. So now to pivot to something more specific, since we're living in the midst of a pandemic, and that is clearly a very salient public health concern, I wanted to ask what factors you see which could have contributed to the different responses we've seen to the pandemic among countries around the world. So whether that can be attributed to different specific aspects of society. So whether that's culture or economic factors or political instability or outside influences. So if you've considered any of that in your work.
Yeah, I am in awe of the East Asian countries and how well generally they've done in the face of the pandemic. I mean, in some cases, in the case of China, it's just draconic stuff that the government is doing. But in other countries, it's something else. It has to do with the culture. And this is what I want to suggest, is that the East Asians have given us 3 cultural contributions that can help us contain the virus better. The first is they've known for a long time, and this one actually comes from South Asia, but the East Asians have adopted the namaste instead of the shaking hands thing. It's a cultural thing that's probably going to stay with us for a long time. The masking. The Japanese have been masking themselves out of a communitarian effort to contain diseases. They've been doing it, well, I thought it was 1918, the pandemic, but actually I know recently that they've been doing it for centuries. And the most important, the most interesting thing to me is that just from reading my hometown newspaper, the LA Times, it turns out that Little Saigon in the Vietnamese neighborhood in Orange County, Little Saigon is like an island of almost no COVID in a sea of horrible pandemic. And what's responsible for that? Well, the Vietnamese are one of the latest transplants into the US, and their cultural tradition of honoring their elders has kind of persisted into Vietnamese Americans now. So the young Vietnamese Americans, to my understanding in Orange County, that they will do nothing, they will not do anything that will put their elders in danger. And as a result, they in their community has contained the virus. So I think there is something in these countries that from protecting the elders, from just having a thing that we're all in it together, that we just don't have enough of. And I think we can learn a lot from them.
I mean, I'll say in addition to this sort of cultural question that's related to Professor Cohan's earlier mention of American individualism, a lot of other countries subsidize people staying inside, paying some sort of financial benefit for people to not have to go to work, right? And so in the US, there are some people who are perhaps being a little bit reckless or doing things that I would prefer that they not do, like going to a motorcycle, rally in another state or something like that. That maybe isn't a great idea, but a lot of people, especially younger people, have to go to work and may or may not be protected in their work environment. And so another thing that a lot of other countries did, which is related to their sort of broader histories of social welfare and safety nets in these other countries. It's not just about healthcare in this pandemic, but involved basically making sure people didn't have to go to work because they were going to starve because they weren't going to get any money. So that's a major intervention of some other countries that didn't necessarily involve some of these like surveillance technologies or practices that I found somewhat troubling in some countries that actually did a good job controlling the pandemic. There's sort of like a debate about the privacy concerns that those might create, but paying someone money to stay inside doesn't create any of those concerns. It perhaps might lead to claims of socialism, which some people might find politically problematic in a way that dissuades folks from supporting a policy like that. But I think that's a very good and easy example of how folks, even in countries that are sometimes denser, or at least have a lot of denser areas, we're able to control spread much quicker. And also, I don't know how every other country works, but in the US, the system of federalism, I think, has also sort of hampered the approach in some ways, although not necessarily that the federal government would have done a great job with that. But early on, we saw states sort of competing with each other. States wouldn't do the same sorts of, for medical supplies, states wouldn't do the same sort of policies on things like masking or stuff like that. And so some states that adopted strong public health measures early on were able to limit some spread, and other states weren't. And so, every country sort of operates differently, but the US system of federalism is pretty central to the country. So I think that's another difference between our system and some other country systems.
So I don't know if I can share the screen. Am I allowed to share the screen? Just briefly? Yeah. Are you able to see my screen that I just shared? So I just also want to give you some background of the coronavirus, that there are about 7 different types of coronavirus that's been identified across the globe. And then the last 3 of them are actually human-based coronaviruses, compared to the other 4 are pretty much more like a flu. So it's not really as fatal compared to the COVID-19. So what I can tell you about the global health perspective is that when you look at the SARS and MERS, they also had some breakout in early 2002 to 2004 and also 2012. And some of the countries have really learned a lot from these outbreaks, especially when you look at the Chinese, Korean, Japanese, and Taiwanese country, the government, like they have experienced a different type of outbreak in the past 20 years. And then so when they actually found out the COVID-19 that broke out in December 2019, they actually had better sense of how to manage these outbreaks. So this is one of the reasons how they manage the epidemic and the pandemic of the COVID-19 really well in some of the Asian countries. But also, I agree with Dr. Cohan talking about the cultural factors, because it actually has a lot to do with the cultural factor, and because the US is more individualistic, but like my own home country, for example, we are much more like, I don't know how to say it, but we are not really that individualistic. So that actually helped shaping how to manage the COVID-19 breakout, like more responsive and more how to act fast compared to other Western countries. So I guess, so it could be the experience from previous outbreak in the 2002 and 2012 for SARS and MERS, which actually helped them to prepare for COVID-19, and also the cultural factors. So those are two other explanations. Yeah.
Thank you. I also wanted to ask Professor Cohan, your expertise lies in evolutionary biology. And I was wondering if we can theorize about how human behavior has influenced or allowed for the kind of evolution of SARS-CoV-2 or the growth and the scale of the pandemic today.
Okay, thank you. Yeah. Yeah, this is really an enigmatic virus with regard to the theory of how virulence should evolve upward and downward. Because the thing is that most of the, well, let's say a good part to half most of the infection is in the asymptomatic or pre-symptomatic stage. And the way that the virus gets from one person to another is not from the lungs, it's not from the kidneys, it's not from the heart, it's not, it's from the upper respiratory system. And basically it can transmit very effectively without causing any symptoms. So the question is, why does it? Why is it so nasty? And how would we expect it to evolve into the future? And I'm not sure if that's the question you want me to answer, but the thing is that why is it so nasty? Well, the thing is, all viruses have a receptor cell, a host receptor protein that the virus will bind to. And our receptor protein, the COVID virus's receptor protein is this ACE2 protein, which unfortunately is in many of our cells, most of our cell types. So the virus it isn't really targeting just the upper respiratory system. It's kind of as an accident that if it's going to do well in the upper respiratory system, it also has the capacity to infect all these other cells that aren't going to do it any good, but that's just where it is. And I would guess that if there is a way that the virus could maintain its ability to be transmitted from the upper respiratory tract without infecting all these other cells, it would probably do a lot better, and that would evolve, but it might not be possible. And another thing that's really interesting is that this virus cheats in one way. Like, what do we mean by asymptomatic? Well, usually it means that the virus isn't hurting you. But in this case, what we found very recently in the last week or two is that the virus actually produces a painkiller. so that you don't know that your throat and your nasopharyngeal passages are being ravaged. You don't feel it. So you're feeling asymptomatic longer, and you're going out with your friends and blowing your virus breath out without even knowing that you have a virus. So that is a dirty trick that this virus does. And I don't know of any other virus that does that, but it's just so specialized to 21st century humanity. And there really isn't any way that, well, I shouldn't say that. As I say, the East Asian countries, if it was up to them, if they were all of humanity, this virus would go extinct. And as it is, we kind of US kind of makes up for them. And the only way we're going to control this thing, I believe, is through vaccination.
Thank you. Langston, you had our next question?
Yes, thank you. So with a lot of this in mind, do you all see a future for a centralized global public health system? Have you considered how a centralized global public health system may ameliorate or add to these current health disparities? And it may be helpful to frame this maybe in our current moment, dealing with COVID. What is there to say about an international effort, so to speak, to get the COVID-19 pandemic under control?
So what do you mean by centralized global public health system? You mean like the WHO organization or something else?
Yes. So the WHO, Amnesty International, these Leading the Gaps, these types of organizations, exactly those types of centralized, global public health. So yeah, definitely like World Health Organization, those efforts.
So I am quite skeptical about the global public health being centralized because each country had their own thought about how to protect their own citizen. And I mean, for example, like even in the like the vaccine, for example, like the Pfizer and the Moderna, I think they are trying to develop new vaccine. And I feel like those vaccine, if got approved, I think they will go to the US citizen and other industrialized country first, and rather than going to the other developing country equally. So I don't know how that kind of disparity would be ameliorated anytime soon. So I think this is something I should think about, but I think there should be some disparity on and on, even when they develop the new vaccine for COVID-19, for example, because there are a lot of regulations and people, and also a lot of politics involved. So, yeah.
Well, I think so. Centralized public health. I think, just as an example, in this country, if we had a centralized, from the federal government sort of policy and mandates against certain behaviors, we would be a lot better. If the president of the United States could say, okay, look, everybody's got to wear a mask. Now, the president does not actually have the legal power to do that, but the president has the moral force to do that. The president says, we're all going to get through this if you just wear the mask. And that's pretty much what Biden has been saying, and he'll be president soon, and then we'll be able to do that. With regard to truly globalized public health, the way I see it is that if we had at least a kind of a minimum bar, at least, of how much public health capacity there was in every single country, that is a certain amount of access to clinics and doctors and nurses and technology and so on, it just seems to me that if that were the case, that say the poorest countries in West Africa had abundant health clinics, then the next time, for example, there is an Ebola outbreak in West Africa, beyond the day-to-day having a clinic and dealing with everyone's health, it would be possible to contain the next virus coming out of nowhere. And I just think that at least that minimum bar would make it possible so that many, many possible emerging viruses would not get out into the world. Of course, in this case, it was a very advanced health-wise country that had released the virus. But I think, yeah, having access to clinics worldwide would really help a lot.
So I also agree that it also had to do a lot. It also had a lot to do with the leadership of the government as a country as a whole, and I don't think I mean, not my own opinion, but also like from the public, that the President Trump and his administration had not really well responded to COVID-19. I mean, there are some evidence on that, and I think it also has a lot to do with the leadership in terms of the epidemic and pandemic, and how to better deal with this kind of the global public health issue. So, yeah.
Professor Shibley, I'm wondering if there are any concerns about globalizing public health in terms of expanding expanding militarization, if you knew what I mean by that, like using health outreach, I guess, or kind of like public health missions that end up furthering military goals, or are kind of expanding U.S. imperialism, for example.
Yeah, I mean, that's certainly possible. So, I mean, if, say, there were some sort of centralized public health system, I agree with Professor Rhee that I think that's pretty unlikely to happen in the sort of way that I think you all might be like theoretically imagining it. But say if there were, like, one of the major ways that folks would probably end up distributing, say, vaccines or other medications, and sometimes have in the past, is through military forces, and that you can't just like compel anybody to go to some other country and distribute some sort of public health measure or biomedical measure like a vaccine. And so a lot of the time that would happen through a military force, and yeah, it could expand, I guess, the militarization or create more contact between civilians and military forces, even if there's no like military engagement per se. And we also have examples of like UN troops, for example, like after the Haitian earthquake, like causing a cholera outbreak in Haiti, even though they were supposed to be like peacekeeping troops. The UN, I guess, was sort of engaged in some kind of mission there that was supposed to be beneficial and not like a war-related mission, but it caused actually a public health problem. And so I think that's a major risk of attempts to use militaries to promote public health measures. And it's sort of hard to imagine like how else a country might even go about a global public health mission, because the way it engages with with other countries is often strictly through the military itself.
I wanted to riff off one thing that you said, Professor Shibley, earlier, with regard to the importance of sick pay in allowing people to stay home when they're sick and not be spreading diseases. And I want to add one thing to that I think is really important. And one thing that's really interesting is that I think it's important also for employers to do what they can to guarantee the infectious disease health of their workers. So, for example, considering like the Smithfield meat packing plant, where people are basically living in a refrigerator where the virus can just exhale and just be around for hours and hours and infect people, that the employers have to be cognizant and respond to the need for proper ventilation and filtering to make sure that their employees will not infect one another unknowingly. So I think that's all really important.
Yeah, and that's actually a great place for federal intervention, right? So we have OSHA that's supposed to enforce things like that. But I think actually at the beginning of the pandemic, the executive branch said we're not really going to make OSHA enforce anything. But that's literally what it's supposed to be there for people to not like get diseases or have other sorts of health problems at work. So we actually do have an agency for that, but we just need to support it, fund it, and actually let it enforce its practices to protect employees at work. Yeah.
Mm-hmm. Thank you. So now we'd like to open up the floor, to our audience. If you guys have any questions for our panelists, if you don't have any questions to say vocally, maybe you can type them in the chat. Does anyone have any questions?
I have a question. So obviously this event is being hosted by Study Abroad. And so people really aren't studying abroad right now in the US, mostly because other countries don't really want us because we are a health hazard. But also, obviously, it's just traveling is very dangerous right now. So what do you think about the prospects of traveling abroad? Because I would really like to next year. And like the dangers of that in the coming months, and I guess maybe depending on country and things like that.
Well, many of us have high hopes that these new vaccines that are so promising will do us a lot of good and make the world safer and make the world safer for travel. I'll just mention that one of the hurdles to getting vaccination to work is that it's not enough for people who are the most fearful to get themselves vaccinated, but we really need to make sure that there's enough trust in the vaccination system, hopefully deserved trust in the vaccination system, such that the vast majority of people will want to get vaccinated. Because think about it this way, if you get vaccinated by a vaccine that has like 90% safety, and you're a geezer like me, you don't really want to run. And if I'm the only person who gets vaccinated, that means I'm going to go running around like I always did and have a good chance of getting of the virus beating my vaccination, a 10% chance. But if there's herd immunity caused by the vast majority getting vaccinated, then it doesn't matter if the vaccine failed to protect me, because we're protecting enough other people that I can just go about my business as if nothing ever happened to some extent. So I have high hopes for these vaccines. We just have to make sure that they're produced, distributed in a non-politicized enough environment so that people are secure in using them. I'll just mention one other thing, that I just read this article in The Conversation, which I highly recommend that newspaper, op-ed newspaper. But they were saying, why is it that the vaccination industry and the vaccination, the industry, why is that it can make some mistakes, some outrageous mistakes over the decades that we've been vaccinating people, and some bad things have happened as a result of just a kind of a hubris. Okay, there's that, but why is it that Volkswagen, the car company, can outright lie about cheating on the emissions tests and just go about their business and they are forgiven? Why is it? What is different between the vaccine, public health folks and car manufacturers? And part of the reason, part of the thing is that we just can't, we in the public health business, what the article was saying is, we cannot be know-it-alls about this. We just have to admit that yes, mistakes are made, we're doing everything we can, and not just say, just listen to us. And I think taking going away from a know-it-all stance to a more engaging stance about what has happened, what the benefits will be of doing this, what the possible risks are, I think we run a better chance of getting the trust of the American people.
The one thing that I was just thinking about is how I've noticed that there seems to be a tendency for people to ignore certain health concerns, especially right now, in favor of other areas, whether that's economic growth or military power. And I'm wondering, well, first if that's also something that you can clearly identify, and also if there would be times when that could be warranted, when there are things that do outweigh health concerns, or if we can kind of always say that, or if you think we can always say that health concerns should be our priority.
I mean, I think it's kind of hard to divorce the other things from the health concerns, right? So one argument that some people have made in favor of promoting economic growth, for example, is because they say in the US that there aren't other sorts of social safety nets, that if folks cannot go to work, they won't make money, and then they'll have other health concerns like lack of nutrition, homelessness, and so forth. Or mental health issues, related to not being able to go out and interact with other people, which I think is actually very important. And so, yeah, I think people use different sort of language to talk about health, but I think sometimes people are actually still talking about health when they're talking about the other things. They perhaps, they might frame it in terms of economics or some other sort of category, but I think it's hard to take those things apart entirely.
Yeah, that's a great point. Do we have any other questions?
Yes, I have a question. I was wondering if you believe that the field of public health will change after the pandemic, and if so, in what ways?
Well, so I think that there will be multiple domains that the public health will basically change over time because of this COVID-19 pandemic. One is basically the preventive approach of the infectious disease. So even after COVID-19, people may still wear masks, or they will still use the hand sanitizer to keep their body clean. And there will also be some of the not just the education-wide, but also the public health practice that will bring into the real world in terms of the addressing this kind of the disaster, like the response of the disaster kind of the public health practice will be more implemented widely in the future. Yeah.
It's interesting to me that after the 1918 flu epidemic, the Japanese never really got over that, in the sense that that was the start of always wearing masks during the flu and cold season. And that's, will we do that? I don't know. We might do it for some time. I would like to think that we'll have a different ethic about always going to work, no matter how you feel. I'm hoping there'll be sick pay. People could just say, like, I'm not feeling very well, I'm not gonna go to work. And maybe the least of all things, and as a microbiologist, we microbiologists, we go to meetings and we're constantly shaking hands, and microbiologists cringe at that, because we know what's on these hands. And I'm really hopeful that one little thing will happen that we'll all do the namaste instead of shaking hands. Oh, wouldn't that be something?
So we're just about out of time. We have one more question? Go for it.
Really quickly, it's about misinformation and sort of maybe a little bit touching points with like the conspiracy theories that have been created within the US and how that has been gaining some ground in other countries as well, with even like political party affiliations now having like the freedom of to choose what to do with one's own body and wearing masks, and we sort of are realizing that it isn't just enough to say, oh, you are wrong. Is there a way that maybe one of you have thought of going about it in a different way, maybe educate in a much more much better manner how these health issues affect everyone?
That's an interesting point. So what's your question? Can you say that? Can you repeat one more time in terms of your question?
Have maybe one of you been thinking of a way to have like a better understanding of how to educate people about the social implications of health?
Well, so I think the politician, and not just the politician, but like people in general, I think they should have better sense of what it means of health equity is, and also what it means of social and behavioral determinant of health, as well as how the constructural I think so how the constructive the society is actually shape our health and access to care of the health care system, and I think that all matters eventually. So I think this is really the public health professional's role in terms of educating those important concepts to the every individual. Yeah.
And in some sense, it's really a matter of having the patience to run a million separate conversations. For example, think about anti-vaxxers and the misinformation about against vaccination. And one of the things that probably just has to happen, is probably the most effective, is if the nurse, let's say, that is at the maternity ward is discussing what the mother and father are going to do about vaccination, and to make it an engagement thing of trying to meet each other. So what are your concerns, and how do you see this, and do you think, and make them aware of certain dangers of not getting vaccinated against measles, but to make sure that you're listening to what the other person is concerned about. Like there was a time that we just assumed that people were worried about the autism misinformation, and most people have gotten past that, but they're still worried. And I think it's really a matter of being ready just to have all these individual health workers have their engagement one-on-one with their patients. That's going to be a really big deal.
I'll say also the idea of there being like some kind of conspiracy theory related to especially like a new disease is actually pretty common. This isn't like a new thing. People have had other sorts of so-called conspiracy theories or beliefs that the government isn't really telling the truth about some kind of disease before. And yeah, it can be really hard to communicate whatever the most accurate public health information is, especially as information changes, and that has been an issue, I think, with this particular pandemic. Oh, well, someone in the CDC or some other organization said one thing, and now they're saying another thing. So the first thing must not have been true. And this is like kind of a long-term problem because it really requires people to be able to engage with the concept of information changing over time. That it's hard to do that through messaging. If you're trying to get people to all do one thing now, they all have to do something else. And there's sort of a broader lack of trust in experts, I think, also over the past several decades, which is not always a bad thing, right? Sometimes so-called experts might not necessarily be trustworthy or might not be equally attentive to needs of all different communities. But in sort of a broader sense, like a broader sort of denigration of, say, medical experts, public health experts, media communicators, and so forth, basically can promote people seeking information from other sources about what health or medical interventions they should take, including some that are not just like from some other source of expertise, but actually really have very little expertise. And that's particularly exacerbated with these sort of internet communities where people get their health information from like other random people on the internet. And so I think it's a very hard problem to deal with, especially once a certain theory has gotten like a big foothold. It can be kind of hard to break that down. But yeah, I agree, that's a big issue.
I think that's a great question to end on. I want to give a big thank you to everyone who came, and especially to our panelists for joining us in this discussion. Yeah, I guess that's all I have to say. Thank you guys for coming. This was recorded, so if anyone has any interest in seeing it later, you can reach out. And yeah, so thank you. Have a good day, everyone.
Thank you.
Thank you.
Thank you.
Thank you.